My name is Allison. I'm going to be your student nurse for today. I'm going to be administering your feeding through your NG tube. I'm going to go wash my hands and get some gloves.
Okay.
I'm closing the curtain behind me for privacy.
Thank you.
I would raise the bed up to working height if we were in a hospital, but since we're not, we're working with what we have. Can you state your name and your date of birth for me?
Jane Doe, 5/6/29.
And do you have any allergies, Jane?
No.
Can I call you Jane?
Yes, you may.
Okay. First, I want to listen to your lungs to make sure I don't hear any adventitious breath sounds, which would indicate pneumonia, possibly from your previous feeding. So take a deep breath for me. Again. 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 One more time. Okay, your breath sounds are nice and clear, indicating to me that there's been no aspiration. Now I want to assess your bowel system. So first I'm going to inspect for any scars, any lesions, anything leaking from any orifice, any lumps. Everything looks within normal limits. So now I'm going to oscillate, starting from the right lower quadrant and working my way clockwise. I'm listening for active bowel sounds, indicating to me that your GI system is working properly. Okay, good. Sounds nice and active in all four quadrants. Now I'm going to palpate in the same fashion, starting in the right lower quadrant, feeling for any distension, any lumps, any tenderness, or heat. Any pain?
No.
Have you been experiencing any nausea or vomiting?
No.
What about diarrhea or constipation?
No.
When was your last bowel movement?
Yesterday.
And it was formed, the consistency was normal for you?
Yes.
Okay. I didn't feel anything abnormal while palpating, so now I'm going to assess the exit site, which in this case is the nares. The other alternative would be on the abdomen, right outside the stomach wall. I'm assessing for redness, signs of infection, anything leaking from there. At the nares, I'm looking for a skin breakdown, but your mucous membranes are nice and moist and your skin is intact. Everything looks normal. So I'm going to check the health record to make sure that the placement of the tube has been verified by x-ray, and it has. So now I'm going to look at the marking that is right outside your nares and make sure that it matches the marking that's indicated in the documentation, and it's at a 2. I see that it's a matching 2 in the health record, so that's good. It indicates to me that it hasn't migrated. I'm also going to aspirate and test the pH of the aspirate. So I'm going to take my syringe and connect it to the tube, her tube, and pull back on the plunger. You want to pull back until there's no more aspirate. If it's more than 60 milliliters, you would have to dump it into a container and continue to pull for 3 to 5 minutes if necessary. Okay, looks like I got everything that's all the gastric residual volume. So I'm going to dump it into a graduated container. And I'm going to take a pH stick and dip it into that container, and it should change color, and then I want to match that color to the box, the key on the box, and it will tell me the corresponding pH. It should be typically between 1 and 5.5, but keep in mind that medications may alter the pH, but I checked and saw that my patient is not on any medications that would alter the pH of the gastric juice, and my thingy tells me that the pH is around 3. That's good and within normal limits. That gives me confidence that the tube is not in the respiratory tract but in the stomach, like where it's supposed to be. The last way that I could verify placement is to take another NG tube and measure the length of it. So with the aspirate, what I want to do is I want to look at the color. It should be like a green, sometimes curdled white consistency, which is residue from previous feeding. You don't want to have too much residue. That could indicate that the GI system isn't working as it should, but she didn't have too much. It was about 50 milliliters of residue, and it's a nice green color. So I want to look at the health record. I would want to look at the health record to see whether it's a gastronomy tube or a jejunostomy tube, because with the jejunostomy tube you wouldn't aspirate because it's not in the stomach, so it's not in a reservoir that would have gastric contents sitting in it. But since she has an NG tube, that is why I aspirated. Now, according to where you work would indicate whether you return the gastric contents back to the patient or discard of them. And depending on how much, if there's too much, you may want to hold the feeding, but hers was not too much. And it seems to me that she's tolerating the feedings well, because you didn't report of any nausea, vomiting, diarrhea. I didn't see any abdominal distension, and there's no pain. So you want to, after you aspirate, you want to make sure that you reconnect the tube and get some tap water and flush it with about 50 to 100 milliliters of tap water, depending on where you work. Make sure that there's no occlusions when it's running down. Hold the syringe about 18 inches above the insertion site. That'll make sure it doesn't go too fast or too slow. So I see that the water went down fine. There's no occlusions. The line is nice and patent. And I would also want to flush again with water after the feeding and make sure that the head of the bed is elevated at least 30 degrees during the feeding and 30 minutes after. I would then make sure to provide frequent mouth care for my patient to decrease the amount of discomfort that she feels from her tube. And now I'm ready for the actual feeding. I'm gonna go get my supplies and leave the patient with the call bell in reach. And do you need anything else before I go grab the supplies?
No, thank you.
Okay.